Today, we're delighted to welcome Dr. Tuya Pal, Professor of Medicine and an Ingram Professor of Cancer Research at the Vanderbilt University Medical Center. Dr. Pal is joining us to debunk myths surrounding breast cancer as it pertains to genetic testing. For those of you that don't know me, my name is Maya Saeed. I'm the co-founder and CEO of Outcomes4Me. At Outcomes4Me, we want to help and empower breast cancer patients with the tools and resources to better navigate their care. Through our mobile app, patients can have access to free resources and information, including clinical trials to help them manage their diseases. And we're rolling out, and actually thanks to Dr. Pal, more resources linked to genetic testing and empowering patients to understand genetic testing, but also facilitate access to the test. So today, the format of today's discussion will be one part presentation and one part Q&A discussion. So far, we've gotten a number of questions from you prior to this webinar, so we'll go through them, but we encourage you all to send us questions via the Zoom link, and we will do our best to get them answered. Feel free to send questions as we go through the presentation. I'll make sure to cover them when we get to the Q&A question. So without further ado, I want to start off by allowing Dr. Pal to give a brief introduction by yourself, and then we'll jump into the presentation. Dr. Pal, please.
Thank you, Maya, for the kind introduction. So as Maya mentioned, I'm based at the Vanderbilt University Medical Center, and specifically at the Vanderbilt Ingram Cancer Center. And I'm a clinical geneticist by training, and I focused on inherited cancer predisposition my entire career, so for over 20 years. So this is something that I'm very passionate about. It's both the focus of my clinical activities as well as my research activities. So again, as Maya already mentioned, I did put together a presentation that I will try to go through fairly quickly so that we have time for the Q&A piece, and please ask away your questions. I look forward to this. So I will start sharing my screen.
And as we start sharing the screen, you can share your questions via the Q&A button at the bottom of your screen.
Okay, and so hopefully everyone can see this. As Maya mentioned, really the focus of what I'm going to talk about is debunking common misconceptions about inherited breast cancers. And in order to do that, I wanted to give a really quick background about inherited cancer. So, first question is, why even identify inherited cancer genes like BRCA1 and BRCA2? And really the whole purpose here is because we have a tremendous opportunity to save lives if we identify individuals prior to development of cancer, and even after development of cancer. So I wanted to show you a real scenario to demonstrate how identification of a BRCA mutation may impact a family. So this is a patient, again, the names are fictional, but the case is real. So this was a patient I had seen a few years ago, Harvey. He'd had breast cancer at age 67, prostate cancer even prior to that, at age 65 with bone mets, and I saw him when he was 73 years old. And what had happened was that the mother, 10 minutes apart, Jawa, had gotten a call from her daughter, Whitney, who was age 45. She had just been diagnosed with stage 2 breast cancer, and her daughter, Missy, age 42, who had just been diagnosed with stage 4 ovarian cancer. Now, Whitney had testing, and again, not surprisingly, she had one of the BRCA genes, specifically BRCA2. She had a double mastectomy as her treatment. Missy, again, not surprisingly, also was tested and had the BRCA2 mutation. And we tested Harvey, and not surprisingly, he had the BRCA2 mutation as well. And you can see here, all of our genes come in pairs. So during the birth of each child, so during each pregnancy, there'd be a 50-50 chance for him to share either the copy with the mutation or the normal BRCA2 gene. So again, he shared the BRCA2 mutation with both of his daughters. And again, 50-50 chance during each pregnancy when someone has a BRCA2 mutation. And when we're thinking about inherited breast cancers, about 10% of all breast cancers are inherited. Yet these breast cancers happen in about 0.3% of women. So you can see the disproportionate burden of breast cancer that is imparted on individuals who have a BRCA mutation or an inherited form of breast cancer. Now, when someone has an inherited cancer identified, so has genetic testing and has a mutation, that really gives us information about the types of cancer risks that they may be at higher risk for. So in the case of the BRCA genes, there's a higher risk for breast and ovarian cancer in women. For men, again, male breast cancer, as well as prostate cancer, and then a slightly higher risk for pancreatic cancer. And this information, the cancer risk information, is what gives us guidance as to what type of tailored prevention options or treatment options we might offer individuals. Now, what's interesting is this is a rapidly evolving field. So again, when we're talking about treatment, there was just a few weeks ago at the ASCO annual meeting, American Society of Clinical Oncology annual meeting, there was a plenary session where they presented the results of the Olympia trial. And what that told us is that even individuals with early stage HER2 negative high risk disease may benefit from olaparib. Now, the reason this is a big deal is for olaparib, up to this point, it's been the later stage or metastatic breast cancers with a BRCA mutation where it was an indication per FDA approval. And again, this isn't yet FDA approved, but this now tells us that across stages of breast cancer, it has become even more important to think about testing because it could guide treatment, even for earlier stage breast cancer. And after this was released, the study results were released, ASCO released rapid guidelines recommending update for patients with high-risk HER2-negative germline BRCA mutated breast cancer. So again, a very exciting update that just happened. Now, to think about this family, if they had had a BRCA mutation identified 6 years ago, how could that have changed their lives? So for Harvey, that could have led to personalized treatments for prostate cancer, also could have led to breast cancer screening. For Whitney, there could have been prevention or early detection of breast cancer. And again, in view of recent guidelines, treatment would be something that could be guided by BRCA mutation status. And then for Missy, there would have been an opportunity to prevent ovarian cancer through prophylactic surgery. So the bottom line is knowing about inherited cancer can save lives, whether it's through, in the context of a cancer diagnosis, through targeted treatments, or whether it's through prevention or sharing results with at-risk family members, which is, again, very, very important. When we're thinking about red flags for inherited cancers, these are just some general red flags, but cancer diagnosed at younger ages than expected, cancers in multiple family members across generations, a person with multiple cancers, either in paired organs or different organs, certain ethnic backgrounds, such as individuals of Ashkenazi Jewish descent, and then certain tumor results. So I wanted to now get into the common misconceptions that we often hear about. So here's the first one that I wanted to go through. I had 23andMe, Ancestry.com, or another direct-to-consumer genetic tests. So I do not need to have genetic testing again. Now, here's the thing. Direct-to-consumer testing versus clinical testing are very different. So, so at-home direct-to-consumer genetic testing doesn't require a medical provider. The scope of results is limited. These results need to be confirmed by traditional testing laboratory, and you can request the raw data from this. And I'll go through some of the issues here. Whereas clinical genetic testing does require involvement of a medical provider. It's usually provided in the context of some counseling. There is insurance coverage if the individual is at high risk. There are many relevant tests that can be offered through in the context of genetic testing for inherited cancer. And interpretation is refined based on the personal and family history. So this is just an example of the 23andMe result. And what you can see here is even on this result, it says results should be confirmed in a clinical setting before taking any medical action. And when we think about testing through 23andMe, it only is limited to 3 mutations. So if you think of each of the genes, BRCA1 and BRCA2, as big sets of encyclopedias or big books, there are essentially 3 spelling mistakes in those books that is looked at. Whereas there actually exist thousands of potential spelling mistakes that can be identified in an individual. So again, you're getting very limited testing when there is BRCA testing through 23andMe. And I think on the test result, that is indicated, but it's not always obvious when it says that BRCA testing was done, but it was very limited testing. And then on top of that, there are, in addition to BRCA1 and BRCA2, there are a number of other inherited cancer genes that are not looked at all in any way, shape, or form through the 23andMe testing. So again, I think the testing is very different when you go through 23andMe. Now, another misconception, the only breast cancer in my family is on my father's side, so I have nothing to worry about. And that is actually not true. Just like women, men can pass on inherited cancer genes, and I think I showed you that in the real scenario that I had gone through. But here's another example where you can see that there's a grandmother here who had ovarian cancer at age 55, and then a granddaughter with breast cancer at age 35. And when you do the testing, the father has not had cancer, but he is the one that transmitted the mutation. So you really need to look at the side of the family where the cancer is coming from. And it's 50-50 whether it came from mom or dad. It really depends on where the family history is. And again, the grandmother was positive, not surprisingly, and the other daughter is actually negative. Another misconception we hear about is, I heard these genes can skip generations. So again, I'm going to go through some pedigrees where it's not that the genes skip generations, it's that the individual actually inherits a predisposition for cancer, meaning a higher risk for cancer, but does not inherit cancer itself. So here you see in this scenario where you have breast and ovarian cancers in the family, and it was transmitted through the father, again, men have lower risk than women overall for having, for developing cancer when they have a BRCA1 or BRCA2 mutation compared to women. But that doesn't mean that they're less likely to have inherited the mutation. So they can still pass it on. And yes, the cancer skips a generation here, but the mutation does not. And this is a similar example looking at another colorectal cancer predisposing condition. So no, the gene does not skip generations, but it's really the predisposition that's inherited rather than the actual cancer. That's why it can look like the cancer skipped a generation. Now, here's another misconception. I'm all done with my cancer treatment, so genetic testing doesn't matter anymore. Now, when we're thinking about BRCA1 and BRCA2, and I've already gone through this in a prior slide, there's a higher risk for breast cancer in both men and women, ovarian cancer, prostate cancer, and even in individuals who have had breast cancer once, there's a chance of developing, a higher chance of developing another cancer in one's lifetime. So having the information about being a BRCA1 or BRCA2 mutation carrier or having an inherited cancer gene mutation can give you information about other cancers for which you might be at higher risk, so that specific preventive or screening options can be offered to you. So again, I think that there are reasons, even if you've had a cancer diagnosis, you're done with your cancer treatment, there are other cancers that may be important for you to consider. Here's another one. I tested negative, but my kids still need testing. Now, it really is not the case at all. So here's a situation we had gone through before, where there's a grandmother with ovarian cancer who has a positive result. Her son inherited it, but her daughter did not. So if someone does not inherit the mutation, they cannot pass it on to their children. So no, if you don't have it, you can't pass it on. So that wouldn't be something where a child would need testing because of the mutation that was present in the grandmother. So some other common misconceptions: I can't have testing because I'm sure my insurance won't cover it, or I can't have testing because if I test positive, I will lose my insurance. So again, this had caused a lot of angst in the past, but I think that a lot of this has been figured out over time. So there was the Genetic Information Non-Discrimination Act that was passed back in 2008. And really what this does is it provides us with protection against discrimination for health insurance, both individual and group health insurance, as well as protections in the workplace. GINA does not address life insurance, disability insurance, or long-term care insurance, so other supplemental types of insurance. But what's important to remember here is there are certain state-specific laws that may address this. So it really depends on the state you're in. I'm aware that California has some protections against discrimination for these other supplemental types of insurance. Florida recently passed a law. Where I'm at in Tennessee, we don't have this type of protection in place. But health insurance is not the issue. It's the other insurances where we worry about discrimination. Military is different though. So again, there are some subtleties to it, but regular insurance, health insurance is not an issue. So covered under GINA, like I already said, health insurers cannot use genetic information to set costs or deny coverage, and most employers cannot use your genetic information. But not covered under GINA, like we already talked about, supplemental insurance, military, Indian Health Services, and some federal health plans. And there are some resources that are available. We also, as Maya mentioned, my interest, longstanding interest, has been inherited cancers, and we do provide a lot of education and outreach through our Inherited Cancer Registry initiative. Again, if you're at all interested in learning more about this, we push out information as it becomes available. We're active on Facebook, Twitter, Instagram, as well as LinkedIn. And with that, I thank you for your attention, and I think we're ready to start the Q&A session. So I will stop sharing my screen.
Perfect. Thank you so much, Dr. Pal. And one of the things I should also add, it's actually thanks to us meeting actually now a couple of years ago. What we've done also is we've integrated the NCCN guideline, which kind of, it for genetic testing in the Outcomes4Me app. So, you could go there, take a questionnaire to see if you are, if you meet criteria for testing. So meaning that if you should get tested for inherited cancer, and if so, we've recently had a collaboration with Invite to facilitate some of the testing, but also kind of with any provider. I want to start. We have a few
Actually,
questions.
Maya, can I expand on that? So, you know, what Maya has developed, in my opinion, is really, really important. And the reason is there are a lot of people out there that don't know that they're at inherited risk, because, you know, if you have a cancer diagnosis, there are some straightforward cases, but even the straightforward cases where you should have testing, sometimes, you know, in the midst of cancer treatment or a new cancer diagnosis, the testing may not be offered, or the individual may not go forward with it. So there's a lot missed on the front end. Like we have known about the BRCA1 and BRCA2 genes for over 20 years. And when you think about how many people we have tested, it's really dismal. Like we maybe know about 20% of BRCA1 and BRCA2 carriers in the US that we should have already identified. So there's 80% of people out there that we have not identified. So I think the value of this app is it simplifies it for individuals, taking your personal history and your family history into account to tell you, oh, do you meet NCCN guidelines or not? So NCCN guidelines are the National Comprehensive Cancer Network guidelines, which are practice guidelines broadly utilized in the US and beyond the US as well, but definitely in the US. And they're kind of complicated. When you look at them, there's certain situations that are clear-cut, but there are many situations that aren't. So this app actually simplifies it for you. So it kind of takes you through a path of answering a few questions and then telling you, hey, you are at high risk, or hey, we're not sure, so you may want to talk to someone, or hey, we don't think you are at high risk, you don't meet guidelines. So I would encourage you, if you are interested in figuring out whether you have inherited cancer, to look at the app. It's super easy to go through. And, you know, again, NCCN guidelines, when you look at the guidelines, because again, anyone can access these guidelines. You just create a user account. It's www.nccn.org. It's free to create a username and password. But when you look at the guidelines, they're not so easy to figure out what they're saying. So this app, I think, simplifies it, and it's definitely an unmet need.
Yeah, no, thank you. And also, I have to say that it's through our conversations, and you mentioned it in the presentation. I personally, that was not, you know, even though kind of I studied genetics, but I didn't realize that, for example, you know, the importance of a clinical grade test, you know, that essentially a direct-to-consumer test, you mentioned 23andMe or others, are only testing us like a few words, if you will, in the gene. And so, you know, depending, you know, it's just not a given that if one is negative, is the reassurance that they're negative for
So I'm going to take it even further than that. Even if someone is positive, that's not 100% either, because there have been many situations where people have gotten a positive test and it was not correct. So, and that's where, like, we make a pretty strong recommendation, and I think it's in the NCCN guidelines as well. If you've had direct-to-consumer testing and tested positive, you still need the clinical grade testing to confirm that result, because it is not always that that result is going to be correct.
Yeah, no, absolutely. And that's actually keeps on evolving. The other thing we do, and I do want to get through some of the questions, is update the guidelines as they update. And perhaps this is actually linked to, you know, one of the questions that we received before, and I saw we got a few now live that I'm going to get to also. But one of the questions we got, which is where I want to start, because we talked a lot about the BRCA gene, is does genetic testing only focus on BRCA1/2 mutations for breast cancer patients? And perhaps I will also add to that the question we got on the chat that I think is a bit linked, where, you know, the person saying she was diagnosed at age 60 with stage 1 IDC, and then, you know, didn't do oncotype, but because it's, you know, the surgeon thought it's strictly age-related. Now, the oncologist finally ordered the test, and I think, if I'm reading it right, the person is BRCA negative. She has 2 daughters, and so her question is also, why isn't genetic testing ordered for everyone BRCA? What age should my daughters start mammogram? My question, because you addressed this by saying, you know, kind of, if the person, the mother, for example, is negative, then that's not going to pass through. So the daughters will not have gotten it from her, essentially it's not.
Right. Unless there's something in the paternal history, right? That's only
Right.
wild card
Exactly.
there. But the mom is the one that's the key. We always like to start testing in the individual that's had the cancer diagnosis, because that will tell us if it's present or not. Now, there's different reasons for a negative test, right? Because, you can be negative because you truly don't have it. But even in the genes that we test for, we're able to get to more than 90% of mutations, but not 100%. So there's always a chance, even with the best technology, that we don't find a mutation. So again, that's why thinking of it in the context of family history is always super important. A negative test to me is not reassuring when I'm seeing this marked family history. And then the third thing is a negative test could be because there's a gene mutation in a gene that we don't yet know to test for. So there's various reasons for getting a negative test result, and a negative test result to me is not reassuring if there is a positive family history, because yes, there may not be additional genetic testing to offer, but there could be targeted screenings to offer just based on family history itself.
Yeah, because as an example, just to kind of continue, if a person essentially has a positive gene, how early does screening start? Like today, the recommendation, I believe, for mammograms is still at age 40 in the general population. But would that start earlier? Yeah.
Yeah, so it would depend on the gene, right? And going back to the prior questions, so I'll answer both questions together. So nowadays, so going even further back, in 2012, we would have just ordered BRCA1 and BRCA2 for the most part, unless we were seeing something in the family history to justify additional genetic testing. And the reason for that is the technology that was used was that each gene would cost thousands of dollars for us to test for. So if you didn't see a justification for it, insurance would not pay for it, right? Around 2012 is when technological advances started being implemented with next generation sequencing. What that means is you can do many, many genetic tests all at the same time. What that also means is, when we think about the BRCA genes, back in 2012, just doing BRCA1 and BRCA2 cost over $4,000. With these multi-gene tests, I can get, say, 70 genes now, or more than 70 genes, and it will cost, even with a self-pay cost, $250. So you can see the magnitude of how much things have gone down. The other thing that happened importantly was in 2013, the patent on the BRCA genes fell. So genes were deemed not to be patentable. And the reason that's important is before 2013, one company had the patent. So they had the entire US market. So even though costs of sequencing were going down, the charges for the testing were going up. Whereas now there are many different companies that can offer BRCA testing. That being said, you still have to be careful. There are companies that crop up that really don't have that much expertise that are offering BRCA testing. So, we don't have any sort of alliances with any lab. We just, through our clinical service as an example, and I would say that that's the case for many of the centers that offer genetic counseling and testing. There are select labs we use. It's not just one lab, it's certain labs, but there are other labs which we would never use because, again, I think even if they are CAP or CLIA certified, that doesn't tell me that they have the expertise that I need to provide the best care for my patients. So again, someone asked, do we only test for BRCA1 and BRCA2? We can test for just BRCA1 and BRCA2, but generally we test broader than that nowadays. Again, the patient would have some input as to whether they wanted a broader test, but in my mind, I generally will test with a larger panel. And again, if the patient wants it limited to just inherited breast cancer genes, we can do that. versus if we want to go broader and test for breast cancer genes and other inherited cancer genes, I will do that. What I'll also say is on these we call them gene panels. So there's panels of genes that we can test for. What happens is, because the labs are the ones adding on the genes, sometimes some of the genes are not ones that are associated definitively with cancer risk. To me, those are useless genes to include on these panels, because even if I get a positive result, I go back to a patient and say, oh, well, I got a positive result, but I don't really know what it means because there is no established cancer risk. So that's not useful to me. So when I do my panels, I tend to do a custom panel where I will only test for genes that I know enough about, where I could provide information to patients if it comes back positive. But again, I don't think there's any right or wrong way of doing it, but there are many options. But most of us don't just limit ourselves to testing for just BRCA1 or BRCA2 in the context of a breast cancer diagnosis.
And also, actually, because you talked about these genes that are not necessarily linked to a given cancer. So I think they're typically referred to as VUS, variant of unknown significance. Is that right?
That's different.
Okay,
yeah,
so maybe if you can explain that, because we did get a question that was submitted before around how likely is that a VUS becomes actionable.
Okay. So just to, again, back up,
yeah.
Whenever we do genetic testing, I think of it like each gene like a big set of encyclopedias, right? So
yeah.
when we do the genetic testing, we're reading through the entire set of encyclopedias, looking for a spelling mistake, which is a positive result. So that's what a mutation is. A negative result is we read through everything and everything looks fine. There's no spelling mistake. The third type of result is what we call a variant of uncertain significance. What that means is there is a change in the genetic code. But if you think about it, we all have variation in our genetic code, right? Variation is what makes us all different as well. So just because you find a variation does not mean it's a spelling mistake. It could be normal variation. And with time, what's been shown, and this was something that was published within the last few years through one of the large labs who've done BRCA testing for a long time, is that with these VUS results, 90% of those reclassified are reclassified as normal. It's only about 10% that are reclassified as being a mutation. So in the context of a VUS result, most times that's not going to guide your care. It's going, and another complexity that's happened over the years is because we have many labs that are doing the testing, sometimes you get these discrepant results. So those are ones where one lab is calling it positive, one lab, and it's not a huge number of cases, but it's important to be aware of those situations because, again, if you go to a genetics professional, they're going to look into that and kind of give you a heads up that this is what is going on. I'm not going to say that that's a huge issue, but it does happen. But VUS results, we don't act generally on VUS results. We treat them as negative results. We rely on the family history.
Okay. Then I do want, so we actually got now talking beyond, actually before I move beyond BRCA, because we have a few questions on other genes and kind of the relation. We had another question that came live now around diet. So the question is, I'm going to read it as is diet and exercise a factor in preventing cancer, or does BRCA2 gene far outweigh these specific precautions? So in other words, inherited versus lifestyle. And if you have the inherited gene, does that outweigh everything else?
Okay, so here's the thing. We always encourage people to have a healthy lifestyle. So eating healthy, exercising, all of that is really good. The issue with BRCA is, like, even if you reduce your risk a little bit with these other, lifestyle factors, the risks are so high, you're still going to have to be proactive with, screening, with, preventive options, or however, there are choices here that people can make in terms of how they want their cancer risk management to go, but no lifestyle change, no lifestyle modification is going to be enough for us to say, oh, you've gotten back to general population risk. That being said, what I would also say is, and I'll use BRCA as an example. So in individuals with a BRCA mutation, what we advise in women is, so there's high risk for both breast cancer and ovarian cancer. For breast cancer, the cancer risk management options in a nutshell are mainly screening through mammograms or and breast MRIs, as well as prophylactic surgery. That's an option.
Prophylactic, just for the audience, prophylactic surgery is preventative mastectomy.
Preventative or risk-reducing surgery. Now, Maya, you'd asked me about age. Age is very much dependent on risk level. So there is, for each of the genes, there are different ages at which risks go up or, stabilize. With BRCA1 as an example, BRCA1 and BRCA2, we recommend the mammogram starting at age 25 annually, and then breast mammograms starting at age 30 added to the MRIs. But for another gene, I'll give you another example, such as ATM or CHEK2, we would start the screening with MRI and mammograms at age 40. So it really does vary by gene. So with the cancer risk management options, for example, if a BRCA carrier has a risk-reducing mastectomy and then at the age where childbearing is no longer a factor, has a risk-reducing salpingo oophorectomy, which means removal of the ovaries and the fallopian tubes, they've gotten themselves pretty close to general population risk. So we actually now have data that there is huge benefits, and it does improve outcomes in these people. And even the MRIs look very encouraging in terms of, being able to detect these cancers early. So regardless of lifestyle, I think, having a healthy lifestyle is good, but I would not get rid of the cancer risk management. The cancer risk management is going to be super duper important.
Okay, and so we got on the chat a question on actually another gene, TP53. So, so the person, so I'm just reading the question, was diagnosed with a variant on the TP53 gene, and then it sounds like her full-blooded brother also was diagnosed with the same variant. The mother tested negative for this variant. The father passed away in 2010 from glioblastoma. So the question, actually, it's a two-part question. One is, first of all, TP53, is it tied to all cancers or only a certain cancer? And then the second question, essentially, this person is a 9-year breast cancer survivor, BRCA negative. The question is recommendation for her kids, which for testing. Currently, her kids are age 17 and 19.
Yeah, so there's many parts to that question.
So TP53 and what it's linked to, and then given the family history.
Yeah, no, but the issue to me is it's a variant, and I would not unless it's a pathogenic or likely pathogenic variant, it's not something we would typically act on. If it is a variant of uncertain significance, that's not something that tells us that there is TP53, unless the family history is super concerning. And again, what I would say is the technology for detection is getting better with time. So some of the ways, there are certain labs that are doing an extra level of testing where they can look at these VUSs to try and reclassify them beyond what was typically available before. So it's a type of testing called RNA testing. So again, it really depends on what that result was. And if it's not a positive result, unless there's something in the family that's telling us that this is definitely Li-Fraumeni syndrome, which is the condition we call that TP53 mutations lead to, I wouldn't call this TP50, I wouldn't call this Li-Fraumeni syndrome. The other thing is, with Li-Fraumeni syndrome, there are various cancers that can pop up. So, you know, in children, leukemias can happen. Sarcomas are also part of the condition. Breast cancer, often at an early, super early age. Oftentimes triple positive breast cancers, more common in Li-Fraumeni syndrome. Brain cancers, also adrenal cortical cancers. So you can see, you get a sense of there's many cancers that can be related to Li-Fraumeni syndrome. So I would encourage this individual to go back to their healthcare provider to kind of get some of these questions addressed, because they're not super straightforward unless you have the whole big picture of what is going on.
Yeah, and I think, yeah, I mean, I see the person has shared more information, but I think we can follow up just so that we can cover a few more questions. But you know, it sounds like it was positive, then negative, and she got breast cancer at an early age, at the age of 39, hormone positive, HER2 negative. But actually, this leads me to just one comment that I noticed as we worked with the NCCN to integrate the guidelines, and also what you said is these tests keep on evolving, and it sounds like, I mean, based on the recommendation from the provider, there may be arguments every so many years to get another test, because
it depends on what the result, like if we figured out what's going on in the family, not so much, but in this case, it does sound like it's high risk. And you know, the flip side of TP53 is when we're thinking about most of these inherited conditions, most of them present in adulthood, right? That we're talking about, like BRCA, we generally do not test children for BRCA because the cancer risks don't, to the best of our knowledge currently, occur in childhood. TP53 is different, and that is one where I would test children because there are interventions that we recommend, such as total body MRI, that happens in childhood or that is offered in childhood. So it's definitely important to think about testing in children depending on what the result is. So that's where, you know, if it's a truly positive result, then that would be something that would be important consideration for kids.
We had another question that was submitted ahead of time around another gene, a rare gene, which is called the Bloom syndrome, BLM. And so the question was, I was diagnosed with HER2 positive new breast cancer in July of 2020. Have been wondering since BLM has duplicate genes, if it has anything to do with my cancer type. Anything on the research on the linkage?
Not to the best of our knowledge. And you know, what I'll say is, with the BLM gene, like I'd said at the beginning, with these panels, there's a lot of genes that are sometimes included on these panels. And BLM has been included on these panels, but I would argue that's one of the genes that is not proven to have an association when it's just one copy of the BLM gene, an association with breast cancer, right? So it's one of those genes that has been included on these panels that probably got included before we had a really robust picture of, is there an association with breast cancer? And, you know, in that vein, there's another gene, as an example, NBN, that has been on all breast cancer panels for a long time. And this was based on data from a single mutation that's seen primarily in the Slavic population. Now, what's interesting is these earlier studies were, you know, not super small, but that's what they were showing. They weren't all that large. Now, we've got much, much larger studies, like significantly larger studies now that aren't showing any association. So per NCCN in the past, we had recommended certain things for NBN carriers with some qualifiers, but over the last few cycles, we've kind of started pulling back and saying, hey, we're not really sure. So again, I think there is a lot of evolution of the literature, and there are genes that we are figuring out do have an association with breast cancer risk, but there are others that we've now figured out we thought had an association, but really don't when we look at the larger population numbers. And the BLM gene, I would say, is not one of those that has been proven to have an association with breast cancer.
No, that's great. We just also got another question on the chat. Actually, I'm interested in knowing what the answer to. So the question is, if you survive, quote unquote, past the age where you typically get ovarian cancer for BRCA2, does that mean your chances of getting it go down? Is there an age where if you haven't gotten it by that age, you're safe?
No, I mean, anyone with ovarian cancer and a BRCA mutation, we make a strong recommendation of getting the ovaries and the fallopian tubes removed. And the reason for that is we have, unfortunately, we don't have anything to offer in the screening realm that's reliable. You know, in the past, we've studied CA-125, transvaginal ultrasounds, pelvic exams, but they're not reliable in detecting ovarian cancer early. So the only thing we have to offer women with a BRCA mutation is risk reducing surgery for through removing the ovaries and the fallopian tubes. What I'll also say is when that is done, it also does reduce the breast cancer risk, particularly if it's done premenopausally. Our recommendation for removing the ovaries in BRCA2 carriers is somewhere between 40 to 45. So it's a little bit later than what we recommend for BRCA1, which is 35 to 40. And the reason for that is the ovarian cancers tend to happen on average a little bit later for BRCA2. But no, I don't think there's a safe age to say, oh, you know, you're past this age, you don't need to consider having your ovaries removed.
We had two questions, one now and the one submitted before that I think are linked. So the two questions is, one, the one we received during the presentation is how long is tissue sample from tumor kept? But I wonder if the person is wondering relative to genetic testing, because then we had another question which is submitted before. What can I do if I don't have a biopsyable disease? Can I still get genetic testing? So I think this kind of difference between testing the tumor versus actually genetic testing, which is not testing the tumor. Yeah.
So when we're talking about genetic testing for inherited breast cancer or inherited cancers in general, we don't need a tumor sample. We're doing it on blood. So really the tumor, so germline testing or testing your constitutional DNA or the DNA that you were born with is different from testing tumor DNA. We don't want or need tumor DNA to do the genetic testing because we want to, and when you think about cancer, cancer is basically uncontrolled cell growth. Cancer itself is a genetic disease, right? Because you have the DNA you're born with that changes, that then leads to uncontrolled cell growth. So it's different from your DNA that you were born with. There are some commonalities, but it's not the same DNA anymore because it's changed. So we really want to get to the germline or constitutional DNA, which is through a blood sample. That's where we can get to do the testing to test for the DNA you were born with. The only caveat I'll make, and this is a very fine point, is say you've had a bone marrow transplant. Well, your DNA that we find in your blood is not going to be the DNA you were born with. So in that case, we'd have to go to a different source, like a skin biopsy or something like that. But for most people, we just do a blood sample. And nowadays, we're actually doing a lot through saliva testing. So there are saliva kits that we send. We see a lot of patients through telemedicine. And for these patients, we'll just send them a saliva collection kit that they can then send into the lab. So you don't even need a blood sample necessarily.
Great. We're going to do just a couple more questions and then we'll wrap up. So if there's any pressing questions from the audience, go ahead and ask it. But we had a question that was submitted around PARP inhibitors, you mentioned actually. So the question is, what are PARP inhibitors and what does this mean for those post-chemo patients that have BRCA2 mutations?
So PARP inhibitors are a brand new class of drugs that were developed particularly looking at the pathway to cancer development that happens in individuals with BRCA mutations. So they are particularly effective in individuals with BRCA-associated cancers. With the clinical trials, what happened initially was that the drugs were tested in those with metastatic breast cancer or later stage breast cancer, whereas now it's moved up in stage where even those with early stage breast cancer may be eligible or may benefit from PARP inhibitors. Now, this is not yet FDA approved, even though ASCO has issued rapid guidelines. I expect that there will be progress in that realm, but I don't know when that will be. But in someone who has already had treatment for breast cancer and has a BRCA mutation, this isn't going to be something you need to worry about at this point. But, you know, should there be something down the road that happens, it could make you eligible for PARP. But again, I don't think there would be anything currently because we're not using it in the breast cancer prevention setting at this point.
That makes sense. I want to end with the last question and then we'll kind of conclude, which you actually in the presentation, you mentioned it, you covered it, but I want to kind of, conclude on it given our audience and a very common misperception, which is also a question that we got. The question is, I already have breast cancer. Why should I get genetic testing done? What's the point? And I think this is a huge misconception that we see. And maybe we can end on the answer to this question and then I'll wrap it up.
Yeah, no, it is something that we've seen a lot with our patients as well. And here's the thing, if you've already had breast cancer and you're through your treatment, if you have an inherited cancer gene mutation, that could give us a glimpse into, well, what other cancers are you at higher risk for? And if we have that information, we can be more diligent with your care, whether it's cancer prevention or screening. The other piece I'll say is we always like to start with the person with cancer in the family, right? So we don't want to start with a child or an unaffected sister, because if we find a mutation or if we don't find anything in them, it's not as reassuring a result, because if someone in the family is negative, but yet we don't have a positive result in hand, it's less informative. So again, with starting with the individual with cancer, yes, it could have your own personal health implications, but beyond that, you are doing your family a huge service, because if you are positive, then it gives an opportunity for other family members, for you to share this information with your other family members who could then be tested. And, like I showed in my first case, had this happened, it would have saved lives, right? So you could literally save the lives of your at-risk family members by knowing this information. The other thing is, if you're negative, your family members really don't need to be tested unless there's something going on another side of the family. Through your lineage, oftentimes that tells us, hey, this isn't inherited cancer. They're still I think it would still be important to factor in the family history piece. But again, testing of individuals with breast cancer is super helpful, both from a personal standpoint as well as a family standpoint.
No, absolutely. And I should say also, given, kind of the integration of the NCCN guidelines that we have in the Outcomes4Me app, the questionnaire walks through some of the questions linked to the family history. So beyond the individual, like if people are wondering about their children, if they still be tested, by answering those questions, they'll be able to see if they meet criteria for testing. As we wrap this up, I'm just looking. So maybe I'll ask this last question just because we just got it on the chat very quickly. So I'm in a chat group with others who have my exact BRCA sentence code. Is it worth us as a group collecting family info, such as family members who's been diagnosed, their ages at diagnosis, treatment, etc.? I'm trying to understand the question. Maybe the question is more kind of, to understand, for research purposes, my guess. I mean, that's my guess, the question.
Here's what I would say. we are getting better with genotype phenotype. I think that's what it's getting at. Do people with the same mutation have the same cancer risk? There may be some truth to it, but I don't think that's 100% the answer. I think there are going to be modifiers, both environmental modifiers as well as genetic modifiers. So your genetic background upon which your BRCA mutation is placed is going to matter. And we already know this. There is a bunch of data that's coming out, you know, related to polygenic risk scores. What we need to do now is integrate these polygenic risk scores. What those are, you know, looking at the genes across the human genome to see, you know, a collective score that gives you a risk. But again, pairing the BRCA mutation with polygenic risk scores is not an easy feat. So what I would say is, this makes it super duper important to participate in registries. And again, from our stand, there are many registries that you can participate in, whether it's at your own academic center. We have one, we've had one for the last 10 years. We have one of the largest inherited cancer registries in the country. And we have over 1,300 BRCA carriers, over 4,000 participants. And if anyone is interested in participating in that, because this is the type of information that we are collecting, and we are collaborating nationally and internationally to kind of address some of these questions. But our website is inheritedcancer.net, but we'd be happy to, you know, and anyone can enroll in our registry. But these are the types of questions that I think many of us are trying to address collectively through national and international consortia.
Excellent. Dr. Pal, thank you so much for taking the time to join us today. We're coming to the end of the hour. And, you know, for our audience, thank you so much for being so engaging and asking questions. If you have any follow-up questions or thoughts, please email us, questions@Outcomes4Me. We will be sending out a survey also after this to get your feedback on what other topics you'd like us to cover. And we'll also be making these videos available in our app along with a blog recap if you want to revisit or share with others. Again, to make sure that you guys don't miss any future updates, please make sure to, you know, get the app if you don't have it and enable push notification. Thanks so much. Stay safe. And thank you again, Dr. Pal.
Okay. Thank you. Bye-bye.
Okay. Bye.